Good evening. We're privileged to have Professor Sir Michael Marmot address us as part of our medical health series. I would like to thank the Education Committee for its support in arranging this. The format of this evening will be a brief introduction, Professor Marmot speak for about 40 minutes, followed by questions and answers. The format of the questions will be slightly different from the usual. If you have a question, please text it to me directly in the Zoom's chat box. Born in England and educated in Australia, Sir Michael Marmot is Professor of Epidemiology and Public Health at UCL. He chaired the World Health Organization Commission on Social Determinants of Health and was President of the World Medical Association. His recommendations have been adopted by the World Health Assembly and by many countries. The British government appointed him to conduct a review of social determinants and health inequalities. The Marmot Review and its recommendations are now being implemented in 3/4 of local authorities in England. With that, I give you Professor Marmot.
Thank you, and a great pleasure to be here. Well, it'd be a pleasure to be with you, but everything's virtual these days. I've called this Health Inequalities. I could well have called it Build Back Fairer. I will show you news of 2 reports that we published with the title Build Back Fairer. But in fact, in the last 12 months, my Institute of Health Equity at UCL has published 4 reports with the title Build Back Fairer. And I mentioned them to make a particular point. The first one, which I'll mention during this lecture, was in December 2020, 1 year ago. The second, Build Back Fairer in the Eastern Mediterranean region of the World Health Organization. The third, Build Back Fairer in Greater Manchester. And the fourth, Build Back Fairer in Hong Kong. And the reason I mention them is that the first one was for a country, England, or we could say for the UK. The second was for a region, supranational. The Eastern Mediterranean region of the World Health Organization consists of 22 countries and territories, from Morocco to Pakistan. The third one is for a city, Manchester, or city region, Greater Manchester, and the fourth for Hong Kong. I kind of think of that as a country, but in fact, it's a jurisdiction within a country. And the reason I'm saying this, it means that action to build back fairer after the pandemic could happen at supranational level, at national level, at regional level within countries, or at the city level. And we need all levels. Good heavens. That wasn't supposed to happen. The opening line of my book, The Health Gap, was why treat people and send them back to the conditions that made them sick? Mostly when people think about health, they think about the health care system. And during a pandemic, particularly, we think about the health care system. Very important. When we get sick, we need access to health care. My concern is with the conditions that make people sick, with the social determinants of health. In February 2020, just before the pandemic crashed upon us, my colleagues and I at the Institute of Health Equity at University College London published Health Equity in England, the Marmot Review 10 years on. To put it in perspective, I have to go back into history a little. As you heard in the introduction, I chaired the World Health Organization Commission on Social Determinants of Health. We published our report, Closing the Gap in a Generation, in 2008. And then Gordon Brown, who was then Prime Minister of the UK, asked me, how could we adapt the findings and recommendations of your global commission to one country, England? And so we set up a review to look at that. We had a fresh look at the evidence, and it was published in 2010 as the Marmot Review, Fair Society, Healthy Lives. February 2010. In February 2020, literally on the 10-year anniversary, we published Health Equity in England, the Marmot Review 10 years on, to see what had happened in the previous decade. And the answer was pretty straightforward. We've lost a decade, and it shows. Life expectancy in England had been increasing about 1 year every 4 years for women and for men. I've taken it back here to 1980. I could have taken it back to 1890 for pretty well the whole of the 20th century. Up until 2009-10, life expectancy increased about 1 year every 4 years. And in 2010, the rate of increase slowed dramatically and just about ground to a halt. What happened in 2010? We had a new government elected, a conservative-led coalition government. They said, surely you can't be suggesting it's anything we did that led to this slowdown. Well, we need to look at it. It's a possibility. It's not a controlled experiment, so you can't say that policy A led to health outcome B, but it's a possibility. Perhaps they said, we've just reached peak life expectancy. It's got to slow down sometime. Well, no, that didn't do it. This is annual life expectancy improvement in weeks between 2011 and 2017. Estonia, Norway, Slovakia, Hungary, Denmark, Belgium, Austria, Japan, Czech, Spain, UK. We had the slowest rate of improvement in life expectancy of any rich country except Iceland and the United States. Note, we had not reached peak life expectancy. Something happened in the UK and the US, I'll leave Iceland out of it for the time being, in the UK and the US that was different to what was going on in other countries. If you classify people by where they live and classify where they live by level of deprivation, what you get is a social gradient. So poor people in the most deprived area have shorter life expectancy than everybody else, certainly than the rich. But it's a gradient. The less the deprivation, the longer the life expectancy. The gap between the best off 10% and the worst off 10% is 9.5 years for men, 7.7 years for women. And that gap got bigger over the decade from 2010. The gradient got steeper. Health inequalities increased with interesting regional differences. This is women. If you look at women in the least deprived decile, it's similar for men. In the least deprived decile, the regional differences are quite small. If you're rich, it doesn't much matter where you live. And in all the regions, life expectancy improved a bit over the decade. In the most deprived decile, the regional difference was much bigger. Life expectancy improved in London and went down for virtually every region outside London. So where we were before the pandemic, life expectancy had stopped improving, inequalities were increasing, and life expectancy for the poorest people was getting worse. That really isn't supposed to happen, is it? We're used to health improving all the time. And life expectancy is not the most important measure of health, but it's a good indicator. And it stopped improving, and inequalities got worse, and health for the poorest people went down. Let's look at the regional difference in a bit more detail. I've got the Northeast and London. The Northwest would look similar. So for the least deprived 10%, the difference between London and the Northeast is tiny. And then the greater the deprivation, the greater the disadvantage of living in the Northeast. Or the greater the deprivation, the great living in the Northeast, there's a bigger disadvantage with deprivation. With deprivation, there's a bigger disadvantage of living in the Northeast. That's really interesting. This deprivation deciles is a national classification, the index of multiple deprivation. It shows a social gradient in health in London, the Northeast, the Northwest, but it predicts more strongly in the North than it does in the South. What is it about being in the Northeast and the Northwest that means deprivation is more damaging to your health than it is in London and the Southeast? And if we look at what happened over time, the dotted line is 2010-12, the solid line is 2016-18, and you can see for London, life expectancy improved at every level of deprivation. The gap didn't get smaller. In fact, it got slightly bigger, but it improved across the spectrum. But for the Northeast, it went down for the poorest decile. It went down a bit for the next poorest decile, and no change really until you get up to the 7th decile when there's some improvement. Wow. In my 2010 review, we had 6 domains of recommendations. Give every child the best start in life. Education and lifelong learning. Fair employment and good work for all. Healthy standard of living for all. Wow, in a rich country, everyone should have at least the minimum income necessary for a healthy life. Healthy and sustainable places and communities, and taking a social determinants approach to prevention. What do I mean by a social determinants approach to prevention? We have a National Health Service healthy eating guide, the Eat Well Guide. Look at levels of deprivation. People in the most deprived 10%, were they to follow the NHS healthy eating guide, they would have to spend 74% of household income on food. If they tried to eat healthily, who would pay the rent? And if they paid the rent, who would heat the dwelling? Don't blame people down here for being irresponsible. They're not irresponsible, they're poor. And we know that the majority of people in poverty are in work, more than 50%. They're not irresponsible, they're lowly paid. Now up at this end, people in the least deprived decile would only need to spend about 6% of their income on food to eat healthily. If they feed their children unhealthy food, they're being highly irresponsible. The irresponsibility is for the rich. Poverty is the issue for the poor. So what happened in 2010? The government said they wanted to roll back the state, austerity. And by golly, they did it. In 2009-10, public sector expenditure was 42% of gross domestic product. It went down year on year. So by 2018-19, that 42% had become 35%. We were in the middle of the European range in 2009-10. We were at the low end of the European range by 2018-19. Now, if you think that all that public expenditure, public sector expenditure is all wasted, it's all public sector is very inefficient, doesn't do anything useful, then you can cut it with impunity. If, however, some of the things that that public expenditure does is useful, healthcare, education, local services, social care, if you think some of those things actually make a difference, it's hardly surprising that there should be ill effects resulting from those cuts. Forgive my using rude words, but in my 2010 review, I coined the phrase proportionate universalism. I was trying to combine two concepts. The default position of British social policy is you focus on the worst off, target means-tested benefits. A more Nordic approach is universalist policies. And I was trying to combine them. So proportionate universalism is universalist policies with effort proportionate to need. The NHS illustrates proportionate universalism. It's a universal system, but it's effort proportionate to need. If you've got diabetes and peripheral vascular disease and renal disease and hypertension and ocular disease, the NHS spends a lot of money on you. If you died bungee jumping at 95 when the rope snapped as you plummeted to your death, you probably would not say, damn, I paid taxes to the NHS all these years and never used it. That's the way it works. So to illustrate, actually you could call proportionate universalism leveling up. There's a nice name for you. I just thought it up. Social distribution, so less deprivation, higher life expectancy, for example. If we focus only on the worst off, we miss the gradient. We miss all these people with health disadvantage. So universalist policies applying to everybody, but with effort proportionate to need. What did we get after 2010? This is spending by local government per person, total local authority spending per person in the least deprived 20% of areas. After 2010, spending went down by 16%. And then the greater the deprivation, the greater the reduction. In the most deprived 20% of areas, spending went down by 32%. This is effort inversely proportionate to need. The greater the deprivation, the greater the need, the greater the need, the greater the reduction in spending. Could these regressive cuts in public expenditure have contributed to the slowdown and improvement in life expectancy, the increase in inequality in health, the decline in life expectancy in the poorest areas? Yeah, I think it could. I won't go through all of my recommendations, but let's look at a key one. Give every child the best start in life. Children living in poverty, where poverty is defined as less than 60% of median income. Before housing costs in 2010-11, 18% of children in England were in poverty. After housing costs, that was 27%. Over the decade, that 27% became 30%. How did they do that? Well, if you look at the change in net household income due to tax and benefit reforms after 2010 by income decile. So look at the red, which is working age families with children. If you were in the bottom decile of household income, your income would go down by 20% as a result of changes the Chancellor made to the tax and benefit system. If you're in the second bottom decile, it would go down by 12%. Third bottom decile, go down by less. And the richer you were, the less the reduction. Some reduction up here for the very richest, but nowhere near as big as the reduction for the poorest. I sat with a former government minister in the coalition government and said, your government's policy was to make poor people poorer, and showed him this slide. He looked a bit uncomfortable and said, well, perhaps it was not our explicit policy. Very clever people in Her Majesty's Treasury. They must have told the Chancellor this was the effect of his policies, and he went ahead and did it. Child poverty had been coming down 2013 and then started to rise again. Infant mortality had a steep decline and then started to rise again. This does not demonstrate causation. I can't say that the rise in child poverty led to the rise in infant mortality, but it's consistent. Now, that infant mortality is at a very low level. So even though it rose a little bit, it's still very low. But it is an indicator. If infant mortality is going up a little bit, what's happening to the circumstances in which children are born and grow and develop? Perhaps they're getting worse. Public spending on early child education and care. In Norway, they spend just under $14,000 per child per year, adjusting for purchasing power. In the United States, they spend about $4,000. We look a good deal more like the USA than we do like Luxembourg, Iceland, Norway, Sweden, Denmark, France, Finland, and Korea. We're very miserly when it comes to spending on early child education and care. So we've made poor families poorer. We've increased child poverty. We spend very little, relatively speaking. There's the OECD average, the rich country average, the EU average. We shouldn't be too surprised if we're damaging people through the life course as a result of government policy. I waited 10 years to produce my 10-year on report. I waited only 10 months to publish the COVID-19 Marmot review. We published this, as I said earlier, in December 2020. Here's the social gradient in mortality from all causes. I showed you life expectancy before. This is mortality. The greater the deprivation, the higher the mortality from all causes. And there's the COVID-19 mortality. It looks exactly parallel to the social gradient in mortality from all causes. It suggests the causes of inequalities in COVID-19 are really rather similar to the causes of inequalities in health more generally. I talked to a lot of different groups, and I was talking to an international meeting of dentists, and I showed them this slide: level of deprivation, least deprived, most deprived. It's a gradient in dental caries in 5-year-old children. Wow, it looks like the COVID-19 graph, the social gradient. I was talking to a group concerned with primary prevention of cardiovascular disease in primary care. So I showed them this slide: obesity prevalence in year 6 by deprivation. It looks like the social gradient in COVID-19. What's going on here? COVID's caused by a virus. Dental caries is caused by poor diet, lack of oral hygiene, low fluoride levels. Obesity in children, diet, exercise, stress, but not a virus. It means that to control the pandemic of COVID-19, yes, of course, we need to control the virus, and vaccination is important. I mean, when the health secretary a few weeks ago said it's a race between the virus and vaccination, I thought, is he really as limited as he sounds? What about inequalities? What about dealing with the inequalities? If we have everybody vaccinated, yes, that will make a big difference to controlling the virus, and we'll still have inequalities in health. The pandemic exposed the underlying inequalities in society and amplified them. We're working in different parts of the country. We're working in Cheshire and Merseyside. Wow, the social gradient in COVID-19 mortality. It really is remarkable. I first described this in 1978, the social gradient, and in a study, the so-called Whitehall study of civil servants. And here we are looking at a disease we'd never heard of. 40 years later, more than 40 years later, in a different part of the country, and there's the social gradient in COVID-19 mortality. We're working in Lancashire and South Cumbria, and there's the social gradient in COVID-19 mortality. Quite remarkable. Public health spending, the reduction per person in England was quite extreme, £13 per person reduction, and in every region of the country. But in my view, public health is not just the public health budget, it's the social determinants of health of what I've been showing you. When it comes to comparing COVID-19 among countries, as you know, there's some difficulty doing that because countries fill in death certificates somewhat differently, assign cause of death somewhat differently. So we've been using excess mortality. How many deaths would you have expected in, let's say, 2020, based on the previous 5 years? And how many did we see? And that's the excess. In the first part of the pandemic, here's the UK. We had the highest excess mortality of any country, similar to France, but there's the UK. The US, which was a disaster handling the pandemic, had lower excess mortality than we did. Now it's taken its rightful place as the highest excess, but we're right up there with very high excess mortality. And in fact, there's a correlation. If you look at improvement in healthy life expectancy in the decade before the pandemic, and then excess mortality during the pandemic, there's a negative correlation. So the US actually had a decline in healthy life expectancy in the decade before the pandemic and a big excess during the pandemic. We didn't do very well in healthy life expectancy, and we have a big excess during the pandemic. Denmark, Latvia had a welcome improvement in healthy life expectancy in the decade before the pandemic, and actually had negative excess. They had lower mortality during the pandemic. They controlled it very well. And look what's going on now. The UK, US, when Jeremy Hunt is the chair of the Commons Health Select Committee, they produced their report a few weeks ago and said the UK did very badly at the beginning of the pandemic, but now we're doing really well, they said. And countries that did very well at the beginning, like Taiwan and Hong Kong and Japan, not so well now. What? I look at this data and think, what is he talking about? This is daily cases. There's the UK. And the countries that did well at the beginning, like South Korea, Japan, Hong Kong, Taiwan, there they are. They're doing well at the end too. We've done badly all the way through. Part of the answer had been, well, we've got to be careful not to crash our economy. So we can't take the steps we needed. We might crash the economy. A false opposition. Countries that managed the pandemic poorly had the biggest hit to the economy. This is GDP growth from the previous year, the second quarter of 2020. Peru had a huge death rate from COVID-19 and a staggering hit to the economy. The UK had a huge death rate from COVID-19 and a staggering hit to the economy, but a negative correlation. Taiwan, which managed the pandemic very well, had a very small hit to the economy. Denmark, some hit, but nowhere near as big as the hit that we had. It's a false opposition. Manage the pandemic well, and your economy doesn't get so badly hit. I said at the beginning, I think of health as a measure of societal success. If society is improving, health will improve. If inequalities in society are increasing, inequalities in health will increase. And if life expectancy is falling for the poorest people, it probably means social circumstances for the poorest people are getting worse. And pre-pandemic, life expectancy was stalling, inequalities were increasing, and life expectancy for the poorest people was falling. And that slowdown in life expectancy was nearly the slowest of all rich countries. And then during the first part of the pandemic, we had the highest excess mortality and nearly the highest all through. What's the link? I think poor governance and political culture, social and economic inequalities were increasing. The reduction in spending on public services, we were ill-prepared, and we were unhealthy coming into the pandemic. I was invited by Greater Manchester to work with them. In fact, before the pandemic crashed, then our work got changed because of the pandemic. So we produced Build Back Fairer in Greater Manchester, Health Equity and Dignified Lives. We published our report on the 30th of June. This was the front page of The Guardian on the 30th of June. England 2, Germany 0. Jaw-dropping fall in life expectancy in poor areas. That cliche came from me. In 2020, the fall in life expectancy in England was stunning. 1.3-year fall in life expectancy for men, 0.9 years for women. And in the Northwest region, where Greater Manchester is located, it was jaw-dropping. 1.6 years for men, 1.2 years for women. I said before the pandemic, life expectancy had been, before 2010, life expectancy had been improving about 1 year every 4 years, 0.25 of a year every year. Wow, we lost nearly 7 years in the Northwest of improvement in 1 year for men. And we had a Build Back Fairer framework for Greater Manchester. Early years, children, looks like our 2010 review. Early years, children and young people, housing, transport and the environment, communities and places, public health, work and employment, income, poverty and debt. And then we had these 6 spokes. Build Back Fairer for future generations, Build Back Fairer resources, Build Back Fairer standards, Build Back Fairer institutions, Build Back Fairer monitoring and accountability, and greater local power and control. I've been trying to get healthcare people involved in social determinants of health, and the nurses produced a book on what nurses can do. We produced a volume for doctors on what doctors could do. in addressing social determinants of health. And we're working with the new integrated care systems to ask what they can do. So the recommendations I make to build back fairer include the 6 I had in 2010. Give every child the best start in life, education and lifelong learning, fair employment and good work for all, having enough money to live on, healthy and sustainable places and communities, and taking a social determinants approach to prevention. But we also need to address this, the poor governance and political culture, reverse the social and economic inequalities that have been increasing, reverse the reduction in spending on public services, and deal with the fact that we haven't been very healthy. Put a fair distribution of health and well-being at the heart of all government policy. Thank you.
Thank you, Professor Marmot. That was truly fascinating. We have a number of questions coming in, and if I could first ask a few that were provided previously. The first questions we have are, could you suggest some strategies to increase vaccination rates amongst ethnic minority and disadvantaged communities? And alongside that, the austerity that followed the 2008 financial services crash, there is fear that another wave of austerity will take place after COVID. Is there anything that can be done to reduce the damages to health from austerity, if indeed it does follow?
Well, firstly, on vaccination rates, the studies that have been done suggest the reasons for vaccine hesitancy are, first, people say, well, I'll do it, but I'm busy, I haven't got time, and when I could fit it in. Well, making it easier is pretty hard at the moment to get your booster, because they're trying to get 1 million done, but that's by the by. But so one is a difficulty. Now, that should be soluble to make it easier to get it. So if ethnic minorities are vaccine hesitant because they think it's difficult. The second is, well, it's not for people like me. It's for them, this vaccination. And again, we should be able to solve that one. It is for people like you. It's for all of us, the vaccination. We should be able to solve that one. The third one is far more troubling. I don't trust what the government says. People say, if the government says I should be vaccinated, I don't trust them. Well, by golly, they've been working hard to ensure that distrust. They put real effort into not being trusted. Why would anybody trust what a congenital liar tells you? In fact, the Ipsos Mori, Apollo, does a regular poll on who people trust to tell the truth. And nurses always come in top at around 93%. 93% of people trust nurses to tell the truth. Doctors, about 91%, and then scientists, judges, teachers. At the other end of the scale, 14% of people trust politicians generally to tell the truth. 20% trust government ministers, just behind journalists. At around 23% trust journalists, who are just behind estate agents at 24%. So politicians are not trusted to tell the truth, and they're rightly not trusted. They've given us ample grounds not to trust them. This is not a Boris Johnson thing. This has been going on for a very long time. So that's much more troubling. And if people think a combination of the vaccine's not for people like me, and I don't trust the people who are telling me to get vaccinated, that's deeply troubling. The fourth reason for vaccine hesitancy is conspiracy theories. Bill Gates is injecting microchips into us. Well, we can't deal with that. If people are off with the fairies, then I don't know how to deal with that one. But the trust in government really worries me. That's really serious. And that's part of what I'm saying here. We need poor governance is part of the problem. The question about austerity is a big challenge, isn't it? Have we learned anything from the experience since 2010? Since I published my 10 years on review in February 2020, the evidence has got even stronger that austerity led to the slowdown in health improvement. So are we going to return, to policies of reducing taxes and reducing public expenditure and say, we don't care if poor people get sick and die earlier? What do we elect governments to do? Surely the number one purpose of a government is to protect the population. And if you take policies that predictably will mean that poorer people die earlier, this is shameful. This is really, really shameful. And I'm not arguing from a party political viewpoint. I'm asking, what is government for? And if government is for increasing health inequalities and guaranteeing that poor people die sooner than they would otherwise, there's something really, really wrong here. So if what we think we've learned is once the pandemic is over, we can go back to austerity, that's a terrible mistake, which is why I called my reports Build Back Fairer.
Thank you very much. We have a number of questions coming in, and people should feel free to put them into the chat box. A series of questions from one person. How can we increase empathy sufficiently to influence voting choices away from self-interest? How do we change the narrative to make people care more? And practically, how do we increase prevention spending? A levy, carrot and sticks. What kind of approaches can you see?
I like those 8 questions. And I was talking to my daughter just before I came on, and I said to her, if you dug deep in me and layer after layer, and you keep digging, what you'll find as you the deeper you dig is somebody who believes in democracy. So all the way through, I believe in democracy. There's no authoritarian inside me waiting to get out. I believe in democracy. And I think about 3 countries I care about: the UK, the USA, and Australia. And I think Australia ranked bottom at COP26 in countries' action on the climate crisis. The US is now ranked, the Economist Intelligence Unit ranks countries on the strength of their democracy. The US now ranks 25th in the world as a flawed democracy. For some reason, the UK is still a full democracy, although I'm a bit surprised. And the UK, we've elected a deeply, deeply incompetent person to be prime minister. And say it's not a party political thing. We've had competent conservative prime ministers. We've had competent Labour prime ministers. And at the last election, we had Johnson versus Corbyn. My God, what happened to the strength of our democracy? And, I don't care how left or how right your policies are. The idea that Corbyn was a suitable prime minister or Johnson was a suitable prime minister, makes me very concerned about what's happened to our democracy if we have these deeply unsuitable people to be prime minister. There's something deeply wrong with it. So I don't know how to remedy that. I certainly don't know how to remedy the US one. I'm clear of what the US problem is. Joseph Hacker, a political scientist, wrote a book called Winner-Take-All Politics, and the disproportionate impact of money in US politics. I mean, when the Supreme Court said corporations are people too, and they can give as much money as they like, and they just opened the floodgates, and the huge influence of money in US politics means that the median voter theory has just been thrown out the window. The idea that the interest of the median voter should be represented in the winning coalition just doesn't seem to hold anymore. So there's something deeply wrong, and I don't know how to solve that. I was asked by a senior politician recently, we've got good ideas. We don't seem to be getting our message across to the public, which is part of what was in that question. How do we get the message across to the public? And the politician asked me, can you advise us what we should be doing? And my response was, certain things come with age and experience. And one is knowing what I'm not good at, and I'm certainly not good at telling politicians how to communicate. But I can tell you, I said to him, what I do. I tell the truth. I argue from the evidence. And I engage people in a discussion about fairness and social justice. And telling the truth, arguing from the evidence, and having a discussion about social justice says we should not go back to policies of austerity. Now, then the question is, and it relates to the previous question that asked, what about breaking the link with austerity and poor health outcomes? And it's a question that we're considering every day because, as I mentioned, we're working with Cheshire and Merseyside, with Lancashire and Cumbria, with Greater Manchester, with the North of Tyne Combined Authority, with Luton, with East London. The Mayor of London has asked me to work with him on health inequalities. So we're working with cities and regions all around the country. And in a way, the question we're asking is what can happen at city level, in a sense, despite whatever's happening at national level. Now, I have said that, I've said it publicly, that if the Prime Minister is serious about levelling up, my Build Back Fair report, in a sense, gives the recipe, says what needs to be done to level up. I'm still waiting for the call from Downing Street.
Thank you very much. Questions, any views on teaching moral courage? One of the problems we have is that speaking out costs. One of the comments in the textbooks is, we are literally not allowed to have honest conversations as NHS trust leaders. I'm an ethicist on the board, and the level of moral injury currently is painful. So any views on teaching moral courage, speaking out at costs?
As I said to the politician, I don't know how to tell him what to do or how to tell other people what to do. I know what I do, which is tell the truth, argue from the evidence, and in a spirit of social justice. Maybe I'm just getting older and I care less if I offend people. Maybe that's what it is. And no one's going to fire me for speaking out. I mean, I was giving a lecture in China the other day. Say I give all my lectures from North London, but I was giving a lecture in China, and some of the data was some of the data that I've shown you. And I just said in passing, it may sound like I'm being critical of some of the policies in my own country. And there are two reasons behind that. One, we've got excellent data. And the second is I'm allowed to. I don't think I'll get asked back this particular Chinese university, but it's a strength of our democracy that we have got very good data, and I'm allowed to speak out and be critical. Now, if within particular NHS trusts it's difficult to do that, we have to work hard to change that culture. Personally, I'm not a troublemaker. I don't try and make trouble. I just speak from the evidence. And in fact, by and large, I've not been attacked from the people that implicitly or explicitly I'm criticizing, because I don't say those rotten politicians. I show what the evidence is, and you can draw your own conclusions of it's not the politicians I'm being critical of, it's their policies.
Thank you. One of the questions we received is, what can we as individuals do to help reduce the health gap and to help address this?
Well, maybe that's the answer to the earlier question about the democracy. The more people get engaged with the good society, what the good society means, what do we want? And I'm of a strong view that was reinforced by the pandemic, that what we want as individuals has a heavy dose of the common good. We don't just want the best for ourselves. We want the common good. The reason we should go out wearing masks is to protect other people. Now, you know that if you're, depending what your age group is, if your adult children have been reluctant to visit their parents, is because they wanted to protect you. And so on with your grandchildren. They wanted to protect you. So we understand that our actions have a wider impact. And I think, and I've got some evidence to support this, people are intolerant of the idea that health inequalities derive from the fact that people are suffering through no fault of their own. People vary, if someone's an alcoholic, they might say, well, it's a disease. That poor person couldn't help it. Or they might say, he's got no one to blame but himself. People vary in their reaction to it. But mostly, the kind of ill health that I'm talking about is through no fault of people's own making. I showed you, if you're in the bottom 10% of household income, you can't afford to eat healthily. If your children are obese, it's because you can't afford nutritious food. You feed them biscuits and sugar and goodness knows what, and processed food. And so I think most of us are sensitive to the idea that if people's suffering was not of their own making, that's wrong. And we should do something about it. So what can individuals do? They can strengthen communities. They can answer the question of how do we change the narrative of what a better society looks like? And we were a better society than we've become. There was a greater emphasis on the public good. And I think we need to recapture that.
Thank you very much. I'm going to ask one last question, and this is your thoughts on the international aspects of COVID vaccine inequality, whereby the richer countries are having booster jabs and the poorer countries not even their first.
Well, a lot of my activity over the last 16 years since I started chairing the WHO Commission on Social Determinants of Health has been in global health. And we've been very concerned at the inequalities in health between countries. And then with the brilliant, absolutely brilliant success of developing the vaccine for COVID-19, it was unfortunately, regrettably, absolutely predictable that we would have vaccine inequity. At the same time, we were putting such effort into the absolutely, truly, astonishingly brilliant science of developing the vaccine. We should have been putting the same level of ingenuity into ensuring vaccine equity globally. And the idea has been from the beginning, the reason we should be doing it is because self-interest and altruism come together. The mantra from the beginning is no one's safe till everyone is safe. And we can see it with the new variant of the virus. It was said from the beginning of the pandemic, the more virus that there is racing around, the more chances there will be of variants. And the more variants there will be, the more chances that they'll escape the vaccine protection. So we need to get the whole world vaccinated to protect all of us. So there's self-interest and altruism come together, and we didn't do it, and we could have done it. We could have had the same ingenuity into making sure we had scale up. And the cost was trivial. The cost was trivial. $30 billion? What, I mean, it's trivial. The US bailout during 2020 was $2 trillion. $2 trillion. 10% of US GDP in 2020. Immediate. It makes Biden's $3 trillion over 10 years look tiny. $2 trillion. Well, we could have put, I said $30 billion. We could have put $1 trillion into scaling up vaccine production and rollout. And we didn't do it. And now we're reaping, we ourselves are reaping the cost of not doing that, quite apart from the damage that's being done in South Africa, other sub-Saharan African countries, Latin America, Brazil, India, and the like. So it was a soluble problem, and we didn't solve it.
I would like to thank Professor Marmot for a fascinating and hugely thought-provoking talk, which has been really direct and very clear, really focusing on the ideas of trying not just to provide people medication, but not to send them back to the conditions that make them sick and make it recur. And the thought of the reduction of the life expectancy in recent years. And I think it really rings very true with people as it relates to their sense of social justice. With that, I'd like to thank you massively for this presentation. We've really learned a lot, and it's been very, very much appreciated. Thank you very much.
My pleasure. Thank you. Bye.
Thank you very much.
Thank you very much.
Good.
Indeed, thank you. Amazing. Amazing.
Thank you.